about liver pathology. And in that, apart from viral hepatitis, we are gonna deal cirrhosis also. As in the case, when you go for the case continue, you will see some things related to cirrhosis. Even in our main case, you have seen that uh, our patient was worried. He was like, uh, his brother has died because of the alcoholic liver disease, and he was worried that he might not develop the cirrhosis like his brother. Okay, and the same in the for any pathology lecture, we have to know about what are the causes, what are the morphology, both at the gross and the microscopic level. And so we are going to deal with these two diseases, hepatitis and cirrhosis. And here, hepatitis broadly, we mean the viral hepatitis. Okay, we are not going to talk about other type like drug induced or what we call autoimmune hepatitis or bacterial hepatitis. Okay, we are just concerning on the viral hepatitis, and that too, hep the hepatitis virus related hepatitis. Okay, like the you have a hepatitis specific virus. There are certain viruses also which can also cause hepatitis, like HIV, Epstein-Barr virus, adenovirus, and all those things. But we are here hepatotrophic virus like hepatitis A, B, C, D, E, and G. And in that also, predominantly we are going to discuss about hepatitis B and C, because these two hepatitis are known to go into chronic phase, and they are like prone to develop hepatic failure, chronic active, inactive, persistent hepatitis. And at the same time, they have like they can also develop fulminant hepatitis, and for a longer period of time they might get converted to the cirrhosis or hepatocellular carcinoma. So we have like the what are the primary liver diseases? When we do want to see the primary liver diseases, these are the diseases affecting principally liver as their target organ. Okay, other organs can get affected as a complication, but their first target is liver. Okay, so we have viral hepatitis, alcoholic liver diseases, non-alcoholic fatty liver diseases, and hepatocellular carcinoma. Obviously, we have cirrhosis as a complication of these three upper entities. So, primary diseases could be viral hepatitis, alcoholic liver disease, cirrhosis of the liver, NFLD or NASH or NALD, whatever you want to call, you can call it, and hepatocellular carcinoma. Then there are certain secondary diseases of the liver. What do you mean the secondary diseases of the liver? The damage to the liver is not the primary. This is secondary to some other condition, like certain metabolic diseases or certain uh, congenital diseases, or as a part of some patient of severe renal failure can develop uh, hepatic involvement. In that case, we call it as a hepatorenal syndrome. So these are the condition where the liver get affected secondarily. Even in the congestive cardiac failure, liver get affected secondarily. So whenever there is a cardiac decompensation, especially congestive cardiac failure, there is like reduced cardiac input because of the diseases in the heart, or decreased cardiac output, that will lead to the either excessive congestion in the liver or reduced blood supply to the liver. Then we have metastasis to the liver. Okay, in cases of like high grade, as you have seen now, two cancers, the esophageal carcinoma or the colorectal carcinoma, that get disseminated, and liver is one of the most important organ to have secondary malignancy. So secondaries in the liver can also get affected, but here also this is the secondary diseases. And extra hepatic infections involving other part, but liver is getting affected as a part of like as a being a major metabolic organ, so it also get affected and a part of a septicemia. Okay, so these are the secondary diseases, and those which we discussed were the viral hepatitis, cirrhosis, alcoholic diseases, NFLD, and SCC are the primary diseases. So before going to the liver diseases properly, we always look for liver function test. Why liver function test? Because with this test, we can come to a conclusion what kind of the diseases we are dealing with. So we must know what are the markers are in the liver function test and when they get affected. Okay. So when there is an injury to the hepatocyte, or you want to look the principal cell of the liver cell or the hepatocytes. So what we look for the these three enzymes. What are these three enzymes? Aspirate aminotransferases, alanine transferases, and the serum lactate dehydrogenase, AST, ALT, and LDH. AST is SGOT. Sometimes they call it as SGOT. They call it SGPT. Okay, and you have lactate dehydrogenase. These are the three enzymes. When they are elevated, or we see any abnormal result in that, we interpret that the liver cell, the hepatocytes are injured. Okay. The another thing is bilirubin. Bilirubin, that is a normal substance that is secreted in the bile. But when that get affected, it could be either hepatic injury, or as you know, bilirubin also an end product of hemoglobin. So extra hepatic injuries also can have, and the bilirubin comes through the bile. So the post hepatic injuries can also raise the bilirubin. So bilirubin, when it is raised, we need to look for what we have to look for, whether it is extra hepatic or hepatic or post-hepatic. Extrahepatic means, or pre-hepatic means, when whether it is due to something like for the hemolysis or some abnormalities of the hemoglobin, or maybe either due to the primarily due to the liver injuries, or maybe it is due to the obstruction to the flow of the bile. Then we have certain enzymes which are elevated when there the bile canalicular system is injured. These are the enzyme alkaline phosphatase and gamma globulin or gamma glutamyl transpeptidase, GGT. So when these enzymes are elevated, so we can see there is damage to the biliary circulation or the biliary canalicular. Then we have certain things which is produced by the liver, and that is secreted in the blood. We have albumin. Albumin is a very, very important protein, and the major source of albumin is the liver. So whenever the liver is affected, you will definitely get hypoalbuminemia. And these hypoalbuminemia is usually manifested by generalized swelling, pericardial effusion, pleural effusion, and ascites in the patient. Then liver is also important for producing of the proteins which are required in the coagulation, like the prothrombin and various clotting factors. So our patient might have bleeding disorders when the liver is extensively affected. That's why we see clinically, when there is a liver fail, we see the spider angioma. Especially this is due to the dilatation and destruction of the small capillaries. Okay. Then ammonia. Ammonia is principally metabolized in the liver to form urea, and it get excreted through the kidney. But whenever liver is affected, this ammonia is not get metabolized, and whenever ammonia level increases, that is lead to the hyperammonemia or hepatic encephalopathy, where the brain get affected. You might have convulsions, loss of consciousness, fetor hepaticus, flapping tremors, depitular contraction. These are the finding we see. Okay. And then we have the viral markers. Hepatitis viral marker for the screening. Then we have the hepatitis A marker, B markers, C markers, E markers. So these are the important viral markers we do. So you got to know what are you are going to look whenever you're suspecting a patient who's having problem within the liver. These are the markers you look, and you look for their abnormalities. So here we come with the our topic main, viral hepatitis. So hepatotropic viruses. What are these viruses? Hepatitis A, B, C, D, E, G, sometime F. Okay. And these are the virus. They have a particular liking, affinity or love or affections towards the liver. Okay. when we get infected by these viruses, other body organs will not get affected. The virus directly goes in through the circulation to the liver, and there it starts acting its role. So what are the other exam? These are the hepatotropic viruses, and the other systemic viral infection also, as I told previously also, there are few viruses. They can affect the liver as a broad perspective. Liver is affected there, either secondary or with the multiple involvement of the other viruses. What are those viruses? Infectious mononucleosis caused by Epstein-Barr virus. Okay, this might cause a mild hepatitis, especially in the acute phase. Then we have cytomegalovirus. This is sexually transmitted viral infection again, and it can also go through the placenta to the newborn. In cases of the immunocompromised patient, this also causes hepatitis. Even though you don't have, you will find the features of hepatitis, tenderness, raised enzyme, but these markers may be negative, but you might find cytomegalovirus. Then you have the yellow fever virus, which is very common in the African country, transmitted through the mosquito bite. Luckily, alhamdulillah, the disease is restricted to the particular area. It has not, because the mosquitoes are available throughout the world. But alhamdulillah, the virus is restricted. That's why whenever the person who comes for Hajj, especially, they need to have the vaccination for the yellow fever. Okay. So this also affect the hepatitis. Now, what are the clinicopathological syndromes of viral hepatitis? Okay, you have various clinical manifestation of the viral hepatitis. Okay, sometime the virus may remain asymptomatic. Okay, the patient will not have any manifestation, but you do, for some reason, you do the blood test, especially when someone goes for the donation or someone goes for the premarital counseling, and they give their blood and they come positive, but they say we have never been affected with the jaundice. So this is called, sometime they might have recovered also from the infection, they don't know. So we call it as the acute asymptomatic or asymptomatic infection. Then we have acute symptomatic. Okay, this is where you have hepatitis symptoms, the viral markers come positive, but here the person get recover from the infection. Then we have fulminant hepatic failure or fulminant hepatitis, where you get acute infection that will, without going into the chronic phase, will develop severe type of hepatitis with liver failure. And there is massive hepatic necrosis of the hepatocytes. So we call it fulminant hepatic failure or fulminant hepatitis. Usually it is seen sometime hepatitis B, C, and especially with the E in cases of pregnant female. Okay, and then we have chronic hepatitis. The person have the acute symptoms, it goes into the chronicity. Sometimes these chronic hepatitis may be associated with the cirrhosis, sometimes it is not associated with the cirrhosis. Are you following me? You are with me?
Yes.
Yes, doctor.
Yes.
Okay, so far things are clear?
Clear.
Yes. It's
Okay,
Yes.
good, alhamdulillah. So now we go for the pathogenesis. Pathogenesis is simple here. Here's the inflammation of the liver. Okay, hepatitis, liver inflammation. So what happened over here? They have the association with the HLA or one or major histocompatibility complex 1 and the role of CD8 positive T cells, okay, or cytotoxic T cells. So whenever these cells, the virus gets affected, it brings upon the activation of the MHC1 and binding with the cytotoxic or CD8 T cells. So here the cell T lymphocyte, especially CD8 positive T lymphocytes. Okay, this bind to the MHC complex, and that goes in the hepatocyte, and there it will bring the changes of the inflammation, which will eventually lead to the killing or necrosis or damage to hepatocyte, which is mediated with the cytotoxic T cells. So there is general morphological features of acute and chronic hepatitis. Whenever you have the acute hepatitis and there is chronic hepatitis, this is just the schematic representation. You have the portal tract, okay, there you have the bile duct, hepatic art, branch of hepatic artery, and uh, portal vein. Okay, so this is called as a portal tract, where you see the maximus inflammatory infiltrate. Okay, what kind of these even though this is an acute, but you will find principally lymphocytes, plasma cells, and few neutrophils. Generally we see acute infection neutrophil, but here in the acute viral hepatitis, the most commonly you will see lymphocytes, plasma cells, and least commonly neutrophils. Okay, there is also bile duct retraction, or like the bile ducts will become constricted, somewhat smaller in size. There is some necrosis in the periportal area. There is necrotic changes, which is known as ballooning degeneration. The hepatocytes become enlarged. It has a small nucleus and very large amount of pink cytoplasm. It looked like a balloon. That's why we call it as a ballooning degeneration. Along with that, because of this cytotoxic necrosis to the hepatocytes, you will find the apoptosis, and then there is an inflammation. Whenever there is an inflammation, you will also see there is accumulation of the macrophages, and these macrophages will try to clear these ballooning degeneration, degenerated hepatitis or apoptotic hepatocytes. Sometimes, especially in the hepatitis C, you might notice some fatty changes in the hepatocytes. So fatty changes, especially the intracytoplasmic or microvesicular. This is the small droplets of fat. Microvesicular fatty changes are very, very characteristic of hepatitis C. Okay, this is commonly asked question. Which of the following is a characteristic association with the microvesicular fatty changes? Microvesicular. Okay, so microvesicular, it comes, look for the hepatitis C. Generally, the fatty degeneration, the most common cause of the fatty degeneration of the hepatocytes is alcohol. But in alcohol, you will find predominantly macrovesicular. The fat droplets are very big. Sometimes they are so big you will not see any nucleus or any cytoplasm in the hepatocytes. You will only see the large droplet of the fat and very small nucleus at the periphery. But in the hepatitis C infection, it is microvesicular fatty changes. Okay, this is what you see in the acute phase. While it comes to the chronic phase, there is predominantly, here you see the inflammatory cells as a lymphocytes, and they form as a, they look like as a lymph node sitting in a portal tract. They form aggregates, so we call it as a aggregate. And there is bridging fibrosis, the fibrosis between the portal and portal tract, between portal and the central vein, between central and central vein. And so you will find this type of the portal tract and the central vein, portal tract, or central vein. So bridging necrosis and bridging fibrosis is very characteristic feature for the chronic hepatitis. Then you will here in the acute phase, generally you see the ground ballooning degeneration. But in, if suppose the your patient is affected with the hepatitis B, so this surface antigen of the hepatitis B virus get accumulated in the side, inside the, or in the cytoplasm of the hepatocytes, and that is known as the ground glass appearance of the hepatocytes. Okay, so ground glass appearance of the hepatocyte is the feature of hepatitis B, and it is due to the accumulation of hepatitis surface antigen. Okay, while the fatty change, okay, or microvascular fatty change is the feature of hepatitis C. Again, you will find a lot of apoptotic bodies. You, along with the fibrosis, you find the apoptotic body, lymphocyte aggregates, a few macrophages, and if suppose it is hepatitis C, again you will find in the chronic phase as well, you will find the microvesicular fatty changes. You understood the morphological feature?
Doctor,
Yes.
can you explain the round glass cell?
Yes, this is like, suppose once you look into the microscope, inshallah, you will see that in the practical also. So what happen when the person is get affected with the hepatitis B, especially in the chronic stages, the there is high viral load. Okay, these viral particles, especially the surface antigen of the hepatitis B virus, start accumulating inside the hepatocytes. Okay, and they look like, you know what is ground glass. Sometime you see in your home, you will not have the window clearly seeing outside and inside. They are like some frosty, some frozen windows. Okay, that is known as the ground glass, where you cannot see through and through. So it looks like pink deposit where you cannot see through and through. That's why it is known as ground glass cells or ground glass appearance of the hepatocyte. But just remember here, for you at your level, you have to remember ground glass hepatocyte seen with the hepatitis B infection, and that is due to the accumulation of surface antigen. Okay.
Yes, doctor. It's
Okay.
clear.
So in the acute hepatitis, you see the necrosis, ballooning degeneration, apoptosis, fatty changes, especially in case of hepatitis C. Okay. Cholestasis means accumulation of the bile in the bile canaliculi. Okay. Or sometime in the hepatocytes. You see the macrophages aggregates, and see this fatty change has been repeated. Okay. It is hepatitis C, and the inflammation mainly in the portal tract, and the cells are predominantly lymphocyte plasma cells and few neutrophils. In the chronic, you will find again there will be necrosis, inflammation, principally lymphocyte. There will be large number of lymphocyte forming a lymphoid aggregates, bridging necrosis, bridging fibrosis, then ground glass appearances, fatty changes, cholestasis, okay, lymphocyte aggregates in the portal tract. So these are all the features of the chronic hepatitis. Okay, so acute and chronic hepatitis, you will find the necrosis and inflammation, especially in the portal triads, okay, and periportal area. So so when you find that, when this is like, suppose the inflammation is severe, so you will also find them between the periportal area. These inflammatory cells will not be restricted to the portal triad alone. They will be seen between the portal triad. So in that case, you know as the interface hepatitis or piecemeal necrosis. So what will happen when the macrophage will come to clear these inflammation? They will be, you find some area of necrosis, then some normal area, some area of necrosis, some normal area. This is known as the interface hepatitis or piecemeal necrosis. Sometimes entire lobule is involved. We call that time lobular inflammation or lobular necrosis. And sometimes you will also see the necrosis like either the combination of all these, or sometime bridging between the portal vein and the portal triad, or portal triad and central vein, or the central vein between the central vein. And you have the grade 1 to grade 4. If you just see portal inflammation, this is grade 1. Interface or piecemeal, grade 2. Entire lobule is involved, grade 3. And then you will find the confluent or with the combination of all with the bridging necrosis, that is known as grade 4 necrosis or inflammation in the acute hepatitis. When it becomes chronic, you will find the cellular cells and cell are mainly the lymphocytes, large number of lymphocytes, and along with that you will also see the fibrosis. Whenever fibrosis comes, it becomes chronic hepatitis. So as I previously mentioned, whenever the fibrosis come, it is chronic hepatitis. So you will find the portal fibrosis, periportal fibrosis, bridging fibrosis, and cirrhosis. The spelling is wrong. I'm sorry, there should be one H over here. Okay. So you have here also, you have grade 1, grade 2, grade 3, grade 4. Okay. So grade 1, grade 2, grade 3, and grade 4, it is called as a cirrhosis. So here the mainly thing is the necrosis and inflammation. While when this changes with the Fibrosis, we call it as a chronic hepatitis, and fibrosis is a hallmark of the chronic hepatic damage. Okay. So this is called as ground glass appearance of the hepatocyte. See here, you can somehow see through and through to the slide. Okay, even in this cell, when you look at this area here, you can see somewhere through and through. Okay, but when you call it as a ground glass, you cannot see beyond this. Okay, here totally clear. Here you can see some glass, but ground glass, you cannot see any area of the gland. And when you do the staining with the surface antigen for the hepatitis B, these ground glass cells are positive for that. Okay, so you are, remember, special morphological feature of hepatitis B is the ground glass appearance of hepatitis B, and this is due to what? Hepatitis B as HBs antigen or surface antigen accumulation inside the hepatic hepatocytes. Now, as we already discussed about, there are some features of the hepatitis C. You look at the liver biopsy and you can see this look like more commonly as a hepatitis C rather than hepatitis B. What are these? More number of lymphocytes, like they're forming the lymphoid aggregates. Okay. Then you see certain changes, reactive changes along the bile duct. Okay. You see some inflammation, some retraction, some infiltrate, especially around the bile duct, and microvesicular steatosis. Okay, sorry, here written macro, but it is mainly microvesicular. Okay, I will need to change it and I'll send you the change slide. Okay, because this is, I'm using the old slide, I did not notice this changes. Okay, so these are the changes which is very characteristic of the hepatitis C. So clinicopathological syndrome, as we see, acute asymptomatic, okay, infection with recovery, acute symptomatic, fulminant hepatic failure, and the chronic hepatitis with or without cirrhosis. So what do you call, when do you call it is a fulminant hepatic failure? When there is development of the hepatic failure or hepatic insufficiency. How do you know that the patient is having hepatic insufficiency? You will see the low albumin, low level of what you call this clotting or the proteins for the fibrinogen and other clotting proteins. Okay, and the patient progressed to hepatic encephalopathy. That is the extreme stage due to the defect in the ammonia metabolism within 2 to 3 weeks. Okay, and they do not develop chronic disease. They got the acute hepatitis, and within 2 to 3 weeks they develop hepatic encephalopathy, and there is complete liver cell failure. So that condition we call it's the fulminant hepatic failure. And you know, the viral hepatitis is responsible for about 12% cases of fulminant hepatic, and out of these, 2/3 cases are by hepatitis B and 1/3 by hepatitis A. And in cases of pregnant women, there could be hepatitis E. And sometimes fulminant hepatic failure can also occur due to paracetamol ingestion, excessive acetaminophen, paracetamol ingestion, either accidental and suicidal. We had a case when I was in India. So she was like nothing to encourage or something. This is just to tell you about a story. Don't get it like me means this thing. We had a third year medical student. She was suffering from very severe headache. Like you can call it like what some kind of the migraine. Okay, and one day she was so frustrated, she took high dose of paracetamol. Usually in a day, one person should take up to 4 grams of paracetamol, okay, or 8 tablets of the paracetamol of the 500 milligram, okay. But that girl took almost 16 tablets. She was very frustrated, and nothing happened to her. Initial 2 3 days she was fine, but suddenly she started showing weakness, jaundice. First we thought she would have developed this thing, but within a week she progressed to the encephalopathy. And that time when asking her history, she told she was, and luckily she was lucky enough. Her mother sample matched with her. Her mother gave her the transplantation. She underwent liver transplantation, and she got saved. So paracetamol is not a easy drug. So that's why our case also, he was taking paracetamol. That was has been like, even you find any patient who is having liver disease, just try to avoid paracetamol. If giving, give the in lower doses. So what is the morphology of the fulminant hepatitis? Because of the massive necrosis in the liver, liver shrink. Okay, it become almost half of the size, 500 to 700 gram. Okay, from 1.1 to 1.5 kgs, it become 500 to 7. And usually when you take out the liver, especially in the post-mortem cases, when you keep the liver on a table, it will maintain its shape and size. But in fulminant hepatitis, when you take out the liver, you find a small liver, you keep it on a table or in a tray, it will not able to maintain its shape. It will limp, as it look like a piece of fat or something very soft gelatinous tissue. With that only you can see that your patient has died because of the fulminant hepatitis. Okay, and microscopically you see the complete destruction of hepatitis in a contiguous lobule, like one lobule, second lobule, third lobule. Okay, and there is collapsing of the reticulum framework, but the portal tract are preserved in cases of fulminant hepatitis. Initially, you will find very little inflammatory reaction, and with survival for several days, there is a massive influx of inflammatory cells. Okay, because if the patient survive, suppose this fulminant hepatitis, if a patient survive, he does not require liver transplant, he is able to show the recovery. So he will have in the biopsy, you will find many inflammatory infiltrate. So massive necrosis. Liver is small, shrunken, and there is like you will find some congested area, some anemic area, and the liver will not maintain its shape. It will shrink. And the microscopically, you will find necrosis, that will be and the inflammatory cells. But the hepatocytes around the portal tracts are little bit preserved. Then we have chronic hepatitis with or without cirrhosis. So chronic hepatitis, when the chronic hepatitis develop into the cirrhosis, we call it as a post-necrotic cirrhosis. Okay. Though, so if the inflammation is like for a long period of time, so there is continuous loss of hepatocyte in the form of necrosis, like they go from the periportal to the piecemeal to the lobular to the confluent, and there is development of fibrosis. So fibrosis start from the bridging, then the lobular, and their entire lobe cirrhotic. So this will like develop, we grade according to grade 1 to grade 4 chronic hepatitis. Okay, and in cases 20% of the cases, like you cannot find out the cause of cirrhosis. Okay, so most of the time, post necrotic cirrhosis is due to the chronic hepatitis, but sometime the patient will have a lot of fibrosis, lot of like different type of necrotic features, but you cannot find the cause. In that kind, you know it as the cryptogenic cirrhosis, when the cause of the cirrhosis, sometimes you find the alcoholic, viral hepatitis, Wilson disease, there is a big list for the cirrhosis causes. You don't find any cause in a person, in that case you call it as a cryptogenic cirrhosis. This is also a like sometime a favorite question to ask, what is cryptogenic cirrhosis, or they will give like blah 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 blah, and then the one of the option, correct option will be cryptogenic cirrhosis. So cirrhosis, when cirrhosis is called when the entire liver has been changed, converted into the regenerative nodules and surrounded by the fibrotic septa, and you will see on the gross appearance nodules of the varying size throughout the liver parenchyma. You call it as a cirrhosis. So, cirrhosis epidemiology, it is the 12th most common cause of death in the developed countries. Okay, and the chief causes of cirrhosis are the alcohol abuse, viral hepatitis, NASH, non-alcoholic steatohepatitis, Other causes like the biliary atresia, biliary diseases, drugs, hemochromatosis, certain congenital diseases, alpha-1 antitrypsin deficiency, and Wilson's disease. These are the other causes for the cirrhosis. If you don't find any cause, you call it as a cryptogenic cirrhosis. And how do you define the cirrhosis? We must have these three components. Okay, if you don't have these characteristics, any one of the missing, you will not call the cirrhosis. What is the thing? Bridging fibrous septa. Okay, portal tract to portal tract, portal tract to central vein. Fibrosis is the key feature of the progressive damage of the liver. Okay, so as we also saw in the hallmark of the chronicity in the liver is the fibrosis. So one of the feature of the cirrhosis is fibrous septa. The second is the parenchymal nodule. So these are, what are these parenchymal nodules? These hepatocytes have regenerating nodules which is encircled or surrounded by the fibrosis, and they will have a different size. When they are less than 3 millimeter, we call it as a micronodules, and where are more than 3 millimeter, we call it as a macronodule. Sometime you will find the cirrhosis micronodular, sometime you find the macronodular, and sometime mixed. And this nodulity will results from because of there is a persistent injury, and the liver is a stable cell, but it can start multiplying when you have the injury. So what happen, injury comes in the form of anything, alcohol or cirrhosis or hepatitis, that these liver cell undergo regeneration, but these regeneration is abnormal and they are surrounded with the fibrotic scars. So we find these regenerating nodules in the liver and they are abnormal. You will find more hepatocytes, but they are abnormal. They will not function properly. And the third is disruption. These two findings, fibrosis and regenerating nodules, should be seen throughout the liver parenchyma. If you don't find, you find half of the liver, this finding, you will not call it as a cirrhosis. Cirrhosis has to have involvement of the throughout the liver, involving entire liver. So focal injury with scarring and nodularity and fibrosis is not called cirrhosis. And if sometime you find the diffuse nodule without fibrosis, you will again not call it as a cirrhosis. So cirrhosis, nodules, you find different size, small size, less than 3 millimeter, micro, more than 3 millimeter, macro. And the microscope, you see these nodules surrounded by the fibrous septa, and this is seen throughout the liver parenchyma. So what are the main process or pathogenesis? So these are the three main mechanism. Death of hepatocytes, extracellular matrix deposition, especially in the form of collagen, that will lead to the fibrous scar, and there is also vascular reorganization. So this is like normal liver. You have hepatocytes, you have stellate cells, you have macrophage, which is known as Kupffer cells, you have delicate collagen fibers, endothelial cells, okay, and you have space of disc. So this is your sinusoid, this is your hepatocytes, and in between you find the space of disc, quiescent stellate cells, okay, and you have this macrophages in the canalicular side, okay. So this is the normal liver, okay. And whenever there is a fibrosis, what happen over where there is hepatocyte dysfunction due to any reason, that will bring about the inflammation, and these inflammation will activate the stellate cell first. These stellate cells will become myofibroblast, or they will known as the myofibroblast proliferation, okay, and this will bring about fibrogenesis, that is formation of the fibrosis, okay. Again, these Kupffer cells will, because of this dysfunction of the hepatocyte, the macrophage will get activated and they will produce the proliferated marker, especially the platelet derived growth factor, that is also activate the stellate cell to form more and more fibrosis. These cells also will produce fibrogenesis growth factor like tissue growth factor beta. that will again cause excessive deposition of the this thing. There is also chemotaxis of the major chemotactic protein, platelet growth factor, that will again lead to the development of the fibrosis. So this is the main principal mechanism of the fibrosis, started with the hepatocyte injury and the low role of macrophage Kupffer cells and the ito cell or the stellate cells. So there is fenestration. So there is big holes in the sinusoidal endothelial cell. This fenestration will be closed. Okay. So normally this fenestrated because there is a transfer of the bile, which is this is a or the secretion of the liver cell in the hepatocyte. Anything goes through this fenestration. This fenestration get closed due to deposition of thick collagen in the space of disc, and that will impart the function of the sinusoid. So there is defective exchange between the hepatocytes and the sinusoid. The liver will not metabolize uh, the toxins from the blood will not go to the liver, and the good product which is liver synthesized will not come to the circulation. So there is imbalance between that. Then there is shunting. There is like the vascular architecture of the liver is disrupted by the parenchymal damage and the scarring. That will lead to the formation of the new vascular channels through the fibrotic change. These vessels will try to connect the portal region to the terminal hepatic vein, and there is shunting of the blood from the parenchyma. So what will happen? This will not go through the normal vascular structure. Instead, there is shunting, and these vessels go either from the central sinusoids to the terminal hepatic veins. Okay, so there is shunting. Okay, so these toxin products will come more and more into the hepatic veins or the inferior through them there to the inferior vena cava. Okay, this thing you can also understand well with when you know the circulation of the liver or hepatic circulation. Then there is formation of the nodularity. So there is liver damage, and that liver damage, as I already told you, the livers are the stable cell. Whenever there is a damage, they try to cover by this damage due to the regeneration. So there is formation of the regeneration and proliferation and the formation of nodules between the hepatic fibrosis septa. So what will be the final outcome of the pathogenesis? This pathogenetic mechanism, you will find fibrotic nodular liver in which the delivery of blood to hepatocytes is severely compromised. So the blood from the sinusoids will not come to the hepatocyte, and inability to form for or like the hepatocyte will be unable to perform their normal functions. So we have symptoms. You find compensated liver is compensated, but it is able to do its job. Okay, but whenever there is any trigger, anything which will damage the liver, it will get severely affected, and there is decompensated, the advanced stages of disease, when the liver is not able to function. So what do you see in the decompensated stage? There is not much fibrosis. Okay, so patient will be either asymptomatic, or there will be a non-specific symptoms like weight loss, weakness, fatigue. Okay, these are the non-specific symptoms. You will not know whether liver is affected in these patients. You can only come to know with the extensive investigatory mechanism. You have to do the scan, you need to do the blood test, and with that you can see, okay, there is some problem with the liver. Sometimes you can have the liver biopsy and you can see the some preserved architecture, but there is fibrosis. Okay, in the later phase, when the liver is totally decompensated, there is extensive fibrosis. So you will find jaundice because of the excessive bile production. There is pruritus because there is fibrosis. So there will be intrahepatic biliary canaliculi obstruction. So bile will not get into through in the intestine. Instead, it will come to the circulation, and in the when it comes into circulation, it will cause itchiness on the skin. Then the liver is totally compensated. It is not able to form albumin. So there is hypoalbuminemia, decreased hydrostatic and osmotic pressure, for formation of edema and accumulation of the fluid in the cavities. In the more severe cases, you might find there is disruption in the ammonia metabolism, and that will lead to the hepatic encephalopathy. Your patient will show confusion, altered level of consciousness, and sometimes he may go into the coma. And because of there is defective in the coagulation, so you will find easy bruising, excessive bleeding, and the spider angiomas. How do you diagnose? You will find with the first, we will do the liver lab findings. In the lab, you will see the elevated bilirubins, elevated liver enzymes, AST more than ALT. Generally, in hepatitis, ALT will be more, but in the cirrhosis, AST will be more. Okay. Other enzymes like the granular injury enzyme, alkaline phosphatase, and GGT will be raised. Okay. And you also do the recent investigation that is known as elastography or the fibroscan, MRI, and ultrasound. At the end, you need to do the biopsy. Initially, the biopsy used to be the final diagnostic mechanism. If you find all the clinical symptoms, these abnormalities, usually used to go for the liver biopsy. But with these, especially the fibroscan and MRI, you can diagnose cirrhosis. You don't need biopsy. But in certain conditions, what is the actual cause for this cirrhosis? You might need a biopsy. But biopsy will be the final confirmatory test for the cirrhosis. Complication, you have decreased liver function. So when there is decreased detoxification function of the liver, you find accumulation of the toxin, especially the ammonia. Okay. And you will find the hepatic encephalopathy, coma, flapping tumor, which is also known as the asterexis. Okay. Then decrease estrogen metabolism through the liver, so you will find the hyperestrogenemia. So what do you mean by the hyperestrogenemia? You will find gynecomastia, spider angioma, palmar erythema. These are the things you will see due to excessive estrogen in the blood. You will also see the loss of pubic and axillary hair. Okay, gynecomastia in the female, hyperestrogenic symptoms in the female, like in the form of menorrhagia, excessive bleeding, breast tenderness. Okay. Then you also have like decreased albumin production by the liver. You get hypoalbuminemia that is manifested with the ascites, pleural effusion, pericardial effusion, or generalized edema. Decreased clotting factor, you have the coagulation issues, easy bruisability, and the bleeding disorders. And so, what are the four major clinical consequences of the portal hypertension? Whenever there is a cirrhosis, that there is fibrosis. This fibrosis will increase the pressure, back pressure in the portal vein, and the patient will develop portal hypertension. And portal hypertension is one of the like common and the severe complication of cirrhosis. Okay, when the patient develop portal hypertension and the hepatic encephalopathy, it means the disease is very severe. Okay, so what will happen in the portal hypertension? You will find the ascites, portosystemic venous shunt. What is portosystemic venous shunt? You might find the caput medusa. There is communication between the portal and the systemic vein. Anatomy, lot of question will be asked. Which vein get communicated with which hemorrhoids? Varices, esophageal varices, patient will present hematemesis, here bleeding per hour, here dilated or like caput medusa. Like caput medusa is the, it look like the, you see the caput medusa is the, medusa was a lady, her hair was very, very curly. So you think at the head, curly hair head, that it's look like. That's why it's known as the caput medusa. And in anatomy, you have to know what are the connection between which veins over here. Okay, and hepatic encephalopathy. So these are the four changes: ascites, portosystemic venous, congestive splenomegaly because of the portal hypertension. So there is a back pressure in the spleen, and the portal vein is formed through the combination of the splenic vein and the superior mesenteric vein. So there is a back pressure over here, and you will find the congestive splenomegaly. This is also very important point to know what are the four major clinical consequences of the portal hypertension. So here we finish our lecture. These are our references, and I also went through the osmosis on YouTube. This is mashallah very good. You have time, listen to him. He has done an excellent job. Okay. And any doubt, you can talk to me. And I am really sorry for being late. Actually, like my meeting got over late. I have to come out from the meeting for because of lecture. So you need anything?